Once again, welcome to the HIMSS Washington Virtual Summit. This is our fourth session of the summit. We went virtual this year on all our meetings. We're very happy to have you here. We've got a great topic on Physician Builder, and we've got some great experts who are going to be talking about that. There's a presentation followed by a panel. I just wanted to remind you, if you look on your Zoom controls, you'll see a place for question and answer and a place for chat. If you want to start putting your questions in as we get going, David Porter is going to be introducing the panel and also fielding those questions. So we look forward to an awesome presentation. At this point, I want to introduce David Porter. He's our member chair from the HIMSS Washington. The HIMSS Washington group is all volunteers, and we really appreciate the work he's been doing. At this point, David, I'm going to turn it over to you.
Thanks, Dwayne. And thank you, everybody, for being here today. We're pretty excited to have our panelists along with us today. We have Dr. Clarke from Confluence Health, Dr. Fathke from Swedish, and Dr. Tarago from Overlake Medical Center. So without further ado, Dr. Clarke is going to start with the presentation, and then we're going to have a more extended discussion from there, and then questions afterwards. So Dr. Clarke, please go ahead.
Great. I want to thank everybody for joining us today. Yeah, so I wanted, we got a great panel here today who's had a lot of experience in the Physician Builder program. And I just couldn't resist sharing this beautiful picture of Wenatchee. And this is really what it looks like in the spring. It doesn't look like that now because we were thinking that snow is coming the rest of this week, but it is absolutely glorious in the spring with all the apple blossoms. So without further ado, I'll move into our presentation. So I want to introduce Physician Builder first in terms of some initial introduction to what a Physician Builder is, and then I'll move into what our experience is at Confluence, and then I'll turn it over at that point to Dr. Rod Tarago and Dr. Carrie Fathke to further that discussion, and then we'll hopefully get some good questions as to how we use the Physician Builders and maybe what their benefit is. So I'll just go through an introduction here. So what is a Physician Builder? Well, it's a physician who's trained in the behind-the-scenes options for configuration of the EHR, and they really understand what the master files are and the configuration or build tools, and then also the data structure behind the EHR. And they may build in one or more environments, but generally it's in a proof of concept environment. And then the analysts or other members of the team will migrate those and maybe further testing, and the Physician Builders most often participate in that testing additionally. Physician Builders may be specialty specific, and we have specialty specific builders in ophthalmology and emergency medicine, et cetera, at our institution at Confluence in Wenatchee. The Physician Builders generally tend to focus on tools that are primarily used by physicians, nurse practitioners, and physician assistants. So why would we want to have Physician Builders? Well, there's a lot of good reasons, I think. For one thing, Physician Builders really can move through some requests more quickly sometimes than what we're seeing perhaps with standard requests that come through the project team, and may cut out some unnecessary time spent on trying to translate those clinical needs into IT terms and then going back and forth with multiple iterations of design. Now, it still is important that we track these changes and that we have a governance process for any of these requests that come through. I think another benefit of having Physician Builders is an improved communication, and that's between the project team and the analyst team with the end users, because it really prevents people a lot of times from talking past each other. And I've had that experience multiple times where everybody thinks they're talking about the same thing, but they're really talking two different languages, and things get built that really are not helpful or actually are detrimental. Increased efficiencies for the workflows that count. So since physicians really intimately understand their workflows, just even saving tiny amounts of time by making a task slightly more efficient might seem minor, but for those of us in the trenches, you know, for individual users, it's often the difference between ending the day on time and then staying late, or the pajama time, which we all talk about and part of physician burnout. So, and this is especially the case when you do a single task dozens of times a day with clicks and screen scrolls, etc. So getting the physician and the clinical content builders involved really helps the organization identify little tweaks that you can make that clinicians themselves might not even recognize can actually save them time. And then increase overall satisfaction with the system. So workflows, navigation, documentation tools that are designed specific for specialty and subspecialty areas really can improve their efficiency. Builders have in-depth knowledge of the system and understand how it can be modified to fit their workflows. And really it integrates that data movement throughout the entire system, and in the hospital setting, very important to nurses. The ARCH Collaborative through the KLAS or the class from Utah has data that's showing improved physician satisfaction with EHRs if physician builders are present in their system. So, you know, one of the reasons is physician builders are also very accessible with the other end users because, you know, they're in the trenches working with it. So another advantage might be lower turnover and increased knowledge of how things work. So the physicians tend to be more tenured, perhaps, than the analysts or some of the IT folks. And so the chances of physician turnover are lower than they are in IT. So if you have a physician builder program, you can help ensure an institutional memory of why certain decisions were made about the EMR. And then maybe even more important is the last one with the increased leadership in operations. So when you have physician and clinical content builders, you really, it helps to keep the project a clinically led project versus an IT only project. And I think sometimes our implementations might get off the rails because the operations folks are maybe not as engaged as they would optimally be. So who might be involved as a physician builder? And you really want people that do have a little bit of a technical bent. You know, if they're really computer phobes, they're probably not the best people to do this. So technical bent, some early adopters, and hopefully they're really passionate about systems improvement, making improvements, and they have to invest the time to do it. So it's not something where you can just kind of do this on the fly periodically. You really need to spend some time and get proficient in it. Ideally, there are local champions, they have good communication, and then certainly teaching skills, because a lot of our physician builders spend time at the elbow and really showing end users how they might improve their use of the system. And in general, just good problem solvers. So we need these folks integrated with the analyst team. The physician builders need to be trained not only in the tools to build, but also in the organizational update and change control tools. And I think that's really important, that we don't want people going rogue. And so you have to have guardrails to prevent them building something that can inadvertently impact the rest of the system. And we, in our institution, we've certainly made that mistake, and I have too many times. You need a detailed change control policy, and then it really helps to give some feedback to the physicians with analyst buddies, is what we typically call the analysts that we're working with, and really have a good integration with the analysts to make sure that we're really working as a team. So just touch briefly on compensation. There's a lot of different models for that. A lot of people do it differently. In fact, even in our own system, we do it in a number of different ways. And some people just do this out of self-preservation. That means that, you know, if they're really stuck with too many clicks and scrolling and not finding the information they need, maybe they just want to get in the system just to improve it. It saves them time and makes their life a bit easier. Or maybe they're just doing it from altruism. But some folks without any additional compensation, though I think this is less often. Some people are compensated hourly on top of their normal clinical hours. FTE percentage, you may have projects that have grant style funding for this, so I think that's maybe less frequent, and it may be just a monetary stipend. Budget source for this can come out of either the informatics program or out of an admin program or salaried positions or specific project funding. So probably more commonly we got administrative and informatics and this, well, I guess the first three. So I'm going to switch now to our experience at Confluence. And it's been a really interesting journey with this. I was one of the first physician builders here along with our pulmonologist. And right now we have trained 10 Epic physicians and 1 PA. 1 physician's retired. And rather serendipitously, in my opinion, is that the other, one of our Epic certified physicians is our CEO-elect. And I think having that technical background and that understanding of our nervous system, Epic, is going to be really really helpful. Our program started in 2014, and 2 of us are certified both as physician builders and also in analytics. And then our pulmonologist, who started out with me as a physician builder, has retired completely from clinical practice. Initially went as a full-time FTE working as a physician builder, and then the physician builder team does report to the CMIO. Our PA builds half day a week and then actually gets tickets in the queue along with the rest of the analysts, though I often direct him more to trying to do some elbow-to-elbow either education or understanding what where people's pain points are. We have 3 physicians who build intermittently, really kind of as needed when there's either a lot to do or they have a particular project that they're working on. The remaining physician builders are more functioning as consultants, educators, and that's both to the analyst team and to the colleagues, and they really help us direct our build priorities and any optimization in the system. So some of our physicians are compensated by FTE status. We have 1 who is compensated on an hourly basis. And we have started using the content management tool that's in Epic to actually enter all of the build records that we're creating. And that really provides really nice visibility to the rest of the analysts to see the records that we're building and make sure that what we are building is not impacting something that somebody else is working on, et cetera. And I think it really helps to keep everybody apprised as to the new builds that we're putting in the system. So our physician builders are also integrated through the system in our optimization committees that also have analysts. We have 1 Epic advisory committee at this time. We used to have both an inpatient and an ambulatory, but we have combined it, and it actually I think helps having a more universal view across the system, as we have 2 hospitals, 2 emergency rooms, 13 satellites, and about 350 physicians. So our advisory committee is multidisciplinary with pharmacy and operations and other clinicians. We attend the quality committees as IT liaisons, and any work that comes out of quality builds that are needed get translated through the physician builders. And of course, we spend a tremendous amount of time on order set work groups. So here's the specialties that we have represented to date: so internal medicine, hospitalist, family medicine, et cetera. So pretty well represented. I think our most active builders at this time are in emergency medicine, internal medicine, hospitalists, and family medicine, a little bit in anesthesia, and not so much in OB. Our pulmonologist obviously is very interested in what happens in the ICU. So I want to just go over a few examples so I don't monopolize the whole program here, but turn it over to my other panelists. But some of the things that really were physician builder projects that we actually either built almost solely ourselves with very little help actually from some of the analysts. But these are our projects, and we spent a lot of time on predictive models and the configuration for sepsis, deterioration index, et cetera. Built a referral and management guidelines sidebar for primary care to actually help them know what to tests and things to do prior to sending them off to specialists, and also maybe how to manage problems that specialists might not have to see. Change the chart summary for the patient profile to really have a comprehensive view of the chart, and it makes it really nice in admitting a patient to actually just print this out, and it's got it's very robust in terms of the detail about the patient. Synopsis views that are kind of in that same trend, looking for medications, laboratories, and chart notes and how they integrate over time. Certainly referral orders to make it really easy to populate the data with special rules that bring in the information rather than people having to type it in. And then we've certainly engaged our specialists, for training specialists. We've built disease-specific order panels, so rather than just ordering up, let's say, a lipid panel, that we actually have a disease such as pneumonia, and that it brings in all of the orders that are specific to, and directs the care actually in people ordering the right things based on institutional and national guidelines. I won't go through all these, but BPAs, we built many of those, our Medicare Advantage risk dashboards, spent a tremendous amount of time on that and looking at how those dashboards present the information to the end users. COVID dashboards, and then we've also spent quite a bit of time with the telemedicine video visit ramp up, not only in testing, but also in helping end users be successful in those telemedicine video visits. So this is my last slide, and then I'm going to turn it over to Rod to move the discussion further. But I would say that it has been an interesting journey, because at the beginning, the analyst team was quite reluctant to have us join them. And we had to do a lot of relationship building and earn the trust of the analysts, because it really was their territory. But I think after these last 6 years going on now, that we have very much earned that trust, and they really rely on us. And in fact, I wonder in a few of these that we are going to need to do a better job of knowledge transfer, because as some of the things that we've created as physician builders, the analysts really are not that familiar with, especially on some of our sidebar reports, our clinical decision support, and then our predictive models. So I'm going to stop sharing at this point and turn it over to Rod.
Thanks, Jeff. We have a lot of the similar stuff that Jeff has at Confluence. We're not quite as far along on the path of our physician builder program simply because we're younger. We actually only went live with Epic a little over a month ago. But what I think we ended up doing a little bit differently is when we kicked off our project a couple of years ago and we were introduced to the concept of physician builder, which we had, there was and there is a similar program using Cerner, but when we went to Epic, it is actively encouraged. And we had a lot of our informatics team become really interested in it. We've got 15 informatics physicians in our organization at Seattle Children's, totaling of about 4.5 FTE. And of the 15 of us, 14 of us took the class. And it was tremendously valuable. Interestingly, because we were also interested in it, we were discouraged by both our hospital and Epic leadership from doing it so early, because it is typically more of an optimization program. We didn't listen and ended up doing it early. And looking back, it was a really valuable experience, not only because we learned the system up close and learned what it could do and what it couldn't do, but there were a couple of other outcomes that I think were not foreseen, but were certainly valuable. One was, as Jeff mentioned, there was some pretty skeptical Epic analysts at our organization who were worried, are these physicians going to take our jobs? Are we going to become obsolete? By no means did that happen. And so in the process of trying to develop that trust, our relationship with the analysts is so much better now than it used to be, because we've worked really closely. with them. They've taught us how to do things. We've given them our clinical perspective. So that was very valuable. The even bigger one is that actually we ended up being used as a major resource during our project implementation. We ended up building probably about 20 to 25% of our total order sets, built a lot of documentation content. And it was nice having all of these builders who knew the basic tools, so that if for some reason we started falling behind on one place, or we started doing more than was originally planned, we could take up the slack. And we've seen something very similar post go live now, in that while our analysts are in there amongst the thousands and thousands and thousands of tickets that have come out of our go live, they're not really available right now to do a lot of what we will call optimization work. And so if a plastic surgeon says, I want to make some changes to this order set, I'm using this example because I did it this morning. He said he wanted to make some relatively basic changes to his order set. Without the builder program, what would he do? He would put in a ticket. It would get put in amongst the roughly 2,000 still active tickets in our system, and hopefully it'll get done by 2021. In our current state with our builder program, I went into the system. I knew exactly what he wanted because I can use my clinical knowledge to do it. I made the changes. I went onto Microsoft Teams, found one of our analysts, and I said, here are the 4 order panels that I just amended. Can you please migrate them? He created a ticket to get it migrated, and I made the changes at about 7:30 this morning, and by 8:30 this morning, they were in our production system. That is unheard of to our clinicians, and it is such a huge win to be able to have them connect with, as Jeff mentioned, somebody who both has the clinical knowledge and the technical knowledge to show them what can be done and make those changes really quickly. So it's been a tremendous win. And now what we're doing is starting to expand it outside of our 15 informatics physicians. We have about another 15 physicians and APPs who are interested in potentially pursuing the physician builder program, which as long as you use the tools can only help us. So it's been a big win. And I will hand it over to Carrie.
Hi, I am a physician informaticist, and I work actually at Swedish, which is part of the greater Providence St. Joseph Health System. And we have been on Epic in both of our institutions since 2008. So we've had a lot of time to grow a physician informaticist program, and we have very different structures depending on how interested a physician or an APC is involved in doing some of that work. So my role is a system provider informaticist, meaning that I'm a hospitalist, so I co-chair what we call our throughput optimization review team, which is the Epic team that's responsible for all the Grand Central and patient logistics functions. So moving a little bit outside of like what the traditional physician builder role is. And it's because I, like Jeff, got my analytics certification, and I'm working on data model and smart form certification at a analyst level. And the reason we decided to do this and move in this direction is we found for our hospital, all 51 hospitals across our 7 states, that the analyst team had a really good idea of what was happening behind the scenes in the Grand Central modules. However, they didn't understand how it interfaced with clinical roles, nor did they understand how the operations actually happened. And I was a hospitalist as well as like the chief of staff, and so and worked a long time on moving patients efficiently through the hospital. And so they wanted a physician who had an understanding of Epic infrastructure and could translate some of that information into more of a logistics space to co-chair that committee and be at the elbow with a lot of the analysts when they're having discussions and those micro builds. And so I can pull up and look at the records that they're looking, the item numbers they're looking at, and we can have a conversation, as Jeff and Rod mentioned, about that translation between operational and clinical practice to the EHR, and then the EHR back to operational and clinical practice in kind of rapid cycles. We're trying to be more agile with some of this stuff. But as you can imagine, at 7 hospitals, or sorry, 7 states and 51 hospitals, we have some issues with governance. It takes a lot of time to push things through. And so the thing that we're struggling right now as a system is how do we allow for local innovation in a bigger system? And this is where physician builders really are key. What physicians builders can do is rapidly work with more agilely work with smaller teams for rapid cycle innovation, and then do proof of concept work locally before having to expand it across to 51 hospitals. And that's something we're learning how to do. I feel like, you know, medicine is about 20 years behind the rest of industries when it comes to some of this stuff. It's a really new concept. We're having to teach our physicians to kind of be relaxed and not see the EHR as just like a digital paper chart, but to see it as something more dynamic, something that we can innovate on more quickly, but in ways that they don't traditionally use the EHR for, but to get the same information. Like, there's a lot of people who like to type a lot, and we have like discussions about like, well, there's better ways to do that, like problem-oriented charting or using your problem list, and so that way we can innovate locally without putting the burden on physicians or APCs or nurses. And we can kind of just grow that EHR so that we can harness the power of things like predictive analytics and how long is a patient going to stay and what are the outcomes going to be, and then we can get data into the hands of the end users so they can improve their quality processes and improve their performance. And that's kind of one of the things that I'm particularly focused on, is how do we get data into the hands of end users using things like Slicer Dicer or Workbench reports, or some of the other SQL queries that we can do more easily, and with the clinician's focus. So yeah, but it's been really fun. I've really enjoyed this work. This has actually given me a lot more control over my life, and it's also given me a lot more control over my fellow hospitalist life. I work 30% doing physician builder stuff, meaning I build and I do a lot of governance and consultation work. And the 30% of my time is spent administrative and 40% of my time is spent clinical.
Well, that's great, Carrie and Rod. Thanks for your detailing your experience, and I guess we'll open up some questions. One other thing that I was going to mention is that we use a tool that probably most of the EHRs have, and in Epic it's called Signal, but it actually looks at the user stats, and it's sometimes quite helpful for identifying users in the system that are struggling in certain ways with managing their in baskets or the volume of messages that they get or documentation time, etc. And so our physician builder team actually does spend some time with analyzing those end user stats and not only having optimization ideas, but also having some focus on maybe end users that might need a little more help or some tender loving care.
Thanks, Dr. Clarke. Like everyone, or like you mentioned, everyone, we're going to be putting out, or this is the section that anybody can throw out questions into either the Q&A platform on the bottom of the screen on the right. I have a couple questions just to kind of get us rolling here. I would imagine that, well, maybe not. I'm curious if you had any kind of opposition or if it was challenging to get physicians on that side obviously interested in doing build work and in stepping more out of the clinical setting. And if so, how did you kind of go about that? That can be to any and or all three of you, but just curious.
We were lucky in that my predecessor here at Seattle Children's made a great argument for the importance and the value of physician informatics. When I joined Seattle Children's 5 years ago, we had a team of about 7 or 8. Since then, we've grown to 15. And I think this project has clearly shown our value. And we're actually turning people away now. Whether it's related to clinical burnout, who knows? But our team, we just can't we can't accommodate everybody who wants to join the informatics team. Now, doing informatics is obviously involved, and most of our team has some degree, not everybody, but most have some degree of informatics training. Many of us are board certified in clinical informatics, but at the same time, not everybody is. And so what we're doing now is essentially continuing our informatics team, but then adding the physician builders. And I'm hoping that we will, with these new group of physician builders who are not informatics but are still wanting to do it, that they will actually show their value to their divisions. And so we're working through right now how we pay for their time. Right now, we're actually telling them that the division has to pay for their time. But I think having done this before with my division, they will find that very quickly their time spent as a physician builder will pay for itself, because they'll have better content, they'll have more satisfaction, and they'll get things done more quickly.
Thank you, Dr. Trago. Dr. Clarke or Dr. Fathke, did you have any additional thoughts there? Otherwise, there are other questions we can move on. If you wish to.
I don't think we've been quite as fortunate, I think, as Seattle Children's. We haven't had people knocking down the door to do it, and I think a lot of that comes from the fact that we have some very significant access problems in North Central Washington. And we're always busy recruiting for patient care, and I think people are pretty pressed already in terms of their time demands for that. That it's hard for them to walk away from the rest of their colleagues and then take away time from their practice and patient access. So, and another interesting thing that I saw a little bit as this program developed is sometimes you have a person who is more interested, I think, I don't want to say this in a derogatory manner, but maybe itching their own or scratching their own itch. And so I try to guard against having a person who has a very focused interest in something that they want to pursue because they just feel like they want to do it, rather than something that really is benefiting their entire specialty group. So we haven't seen a lot of that, but we have seen a little bit of it. But we don't have quite as many people who can just take the time away, especially in our general surgeon, who is actually pretty interested in getting started with it, but we are just so shy in our manpower that he really hasn't been able to devote as much time as he would like to towards that.
And at Providence, we have, like I said, we have like kind of tiers of people who have different levels of interest. We have people who are like me, who are really kind of hardcore into the Epic build world. We have physician builders who are more interested in just making sure that order sets are okay, or that documentation is standardized. We also have physicians who are more power users, who are super users, who don't necessarily want to take more time from their clinical work, but we kind of, what they gain from that is access to analysts and other key build opportunities. Some of the things that I'm concerned about, though, is building the pipeline and making sure that that pipeline is diverse, that there's a lot of voices in it from different specialties, and also that there's also a lot of voices from different communities as well who are building that, because we all know that building something into the EHR means you're going to kind of guide how people think. We want to make sure we have all the right people at the table to have those conversations, and so that we're not inadvertently building something or creating an algorithm where we haven't kind of looked at it from all angles. So that diversification and making sure we also have younger people in the pipeline coming up through the ranks is also something we've been really interested in. But as we kind of all are acknowledging, being compensated for this work is something that's not standard, and physicians are compensated oftentimes by RVU, sometimes they're salaried. But having systems think about what this means to compensate a physician builder is really, or an APC, is really important, because as much as people want to volunteer to do this work, it's also a special skill set that's absolutely, essentially, in my opinion, required for any institution that wants to kind of grow and develop and have an EHR that's functional for the clinicians.
Thank you. Yeah, and that I mean, that makes sense. I would imagine that the training and education portion and just overall buy-in is a lot easier once you have a successful physician builders program. You and Dr. Clarke also kind of touched on it from a trying to protect the organization, so you're not just building things to build things or building things for one individual specialty. How do you have to put, or have you had to put formal governance structures around that? Or I'm just curious from that perspective.
Actually, I was going to say, to tag on to what Carrie said about that, is not only is the physician builder responsibility to help build things, but what we're really encouraging people to do is not come to us as physician builders or as informaticists to say, I need this. We'd rather have them come to us to say, I have this problem, because a solution may be something in documentation. It may be an order. It may be some sort of decision support. And so because we're trained in all those areas, we're able to tell them, you probably don't want an order set. Here's what I'd recommend. And that's been a big part of the value is, they always, in the film Jurassic Park, there's a scene where Jeff Goldblum is talking to somebody and he said, your scientists were so hung up on whether they could, nobody asked whether they should. And I think that's one of the roles that we play as informaticists and builders is, we could build another order set, but that doesn't necessarily mean we should do that. And we play that gatekeeper role a lot.
Yeah, and I'll tag on to that. I think that's a really important point. And sometimes that actually comes out of operations, which is interesting. And somebody will see a new shiny tool and they'll decide that that's the answer or the solution to the problem before really formulating what the problem is. And I think our informatics team and physician builders actually, the earlier we get involved in that process and can identify a whole host of tools, then the better. I had the experience this last year and really got one of our pharmacists pretty upset because they had settled on a very particular build that was not a foundation build in the system and would have required a lot of customization, but they'd seen it, they really liked it. But unfortunately, the maintenance on that was just going to be horrible. So that's why in my presentation, I did talk about the importance of governance. And we really stress in our system that this is not something that one particular physician builder is going to make a decision about whether it's going to go in or not, but that we help provide the solutions and because we know what the opportunities or what the options are, but then also run it through the governance process that includes multi-disciplinary groups and the analysts, and to make sure that what we're doing really is going to have a general systems improvement rather than some one-off.
And I want to echo that from Jeff and Rod, and I can tell, having gone through many iterations of this, we have found at Swedish and both Providence St. Joseph Health, when you don't do that with the future in mind, you end up with a lot of challenges because if you build something unique and Epic does its upgrade and all of a sudden everything breaks and then people are used to seeing things in one place or having it function one place, but the new Epic upgrade broke it, it's harder to have those conversations retrospectively, and people are much, much angrier. A lot of informatics is carefully managing people's expectations, asking them to bring that problem instead of the solution. For everybody who says, I need an order set, this is the only way we're going to do it is an order set, I say, let's take a step back. Tell me what your problem is, and let's kind of go through this, and let's not be anchored. It's the same thing as teaching medical students or residents too, those cognitive biases. People are coming to you with cognitive biases, and you're right, and Jeff, totally agree with you. What'll happen is operations will hear the complaints from their physicians because they're anchored on the solution. They'll buy a third-party application that just mucks everything up, and then they end up having to support that third-party application. And it turns out that if they had just said what the problem is and not the solution, we could have solved the problem without buying a third-party application. So we've seen this iteratively and iteratively now since 2008. We're trying to become more disciplined about that kind of process. Not only are physician informaticists now sitting on the Epic governance control, we're actually doing it in technology in general. And so our physicians are gaining those technical skills and sitting with the IS teams before a third-party application is bought. We look to see, do we have the resources already within the system in another application that we just haven't optimized? And if so, then let's kind of hold off on that third-party application. We really want to do some scrutiny there too. So it's expanded a little bit beyond the EHR, because people thought technology, just buy another piece of equipment or buy another platform and it's going to solve the problem. We found it just creates more chaos and more complexity.
That's it. And just to add on to that, Carrie, really nicely, I have a great dyad partner in my CIO, and the two of us really speak the same language, and that is, you know, if we already have it in our system, let's not go out and buy something new. Let's go out and use what we have and optimize what we have, unless it really can't provide that. And it seems like that we're always doing that blocking and tackling as it relates, because people really are finding new shiny objects out there that they want to bring into the system. And it really is a constant battle. But I think people don't realize that when you add new systems like that, it just adds to your support and operating base and costs. And it really needs to be, that discussion really needs to occur very early on in the process. But try as we might, people still manage to get a little too far down that pathway, you know, even now.
Yeah, that makes sense. I can only imagine. Out of curiosity, this was a question that came in via the chat. Do you ever foresee, with the burnout rates raising, do you potentially foresee an issue with having a very successful physician builders program, that some of those clinicians may potentially want to step out of practicing medicine and you'll all of a sudden have to turn more and more people away? And how do you deal with that? I know, Dr. Tarago, you kind of touched on that a little bit, but I think some folks have some questions around expanding that thought process there.
Yeah, I mentioned that we have been turning people away. The interesting thing is that what we're hoping to do is, as my two co-presenters have said, is really show the value of informatics. We, at least at Seattle Children's, many people are given administrative time to do one thing or the other. In the end, one could argue that informatics is quality and safety. It is revenue cycle. It is all of those things. There's almost nothing you can do in healthcare that doesn't involve informatics now. And so I think it's getting easier and easier to make the argument. And whether somebody is spending their time administering a fellowship program or running a QI project or doing informatics, in the end, it's all for the same common goal.
And I would say this for, we're kind of, in my opinion, in a time of accelerated need for physician informaticists because of the way technology in healthcare is rapidly changing, particularly among the EHR and some of the other tools, with the some of the work done by the previous administration, you know, injecting money and interoperability mandates. We've been finding that it's like a boon almost. And what happens when you don't have physician builders in some of those discussions, micro decisions get made, which have major impact on the way that physicians and nurses work. And that actually does contribute quite a bit to burnout. And I think as we build our physician builders and APC builders and nursing informaticist teams, what we'll find is the burden of documentation will become much less. Again, thinking of the chart less as a digital copy of a paper chart, but more as in innovative ways to do the work. Right now, most of my note templates are things that I pull in most of the information, and it looks nice. And someone had asked the question about usability. Yeah, I told user interface is major. How many clicks does it take you to do this one thing? How many times do you have to, in your note, find another place where you have to click? How many things do you have to press? What does it look like in the end? Is it easy to read? All of those things require people who do the work to understand it. And so building up that workforce is really essential. And I know it's an afterthought at the moment, but I really think that with this, you know, technological boom, we're leaving old medicine behind. And we're creating new opportunities in medicine. And in order for it to make it sustainable for our physicians, our APCs, and our nurses, we have to have those people who are doing the work at the table to have those conversations in principle design.
Yeah, and I'm going to add on to what Carrie was alluding to, in that the physician burnout piece of this and the documentation burden. Now, it's interesting that with the, as of January 2021, that the new E&M coding guidelines presumably changed the waterfront very significantly. And so we're thinking about that as physician builders, and of course in our informatics team. But again, there's a new battle, and the new battle is that people learned a particular way of documenting and a particular way of navigating the system. And whether they're going to switch to problem-oriented charting or stop bringing the entire chart into their notes and battling note bloat is really, it is difficult to affect that change. People have figured out, they learned one way to do something. They from a survival standpoint, and just time, they want to get through their day. They don't really want to make any changes. And so unfortunately, the rest of us end up seeing the results of that note bloat and this cognitive overload that occurs from just all this information being dumped in. So this is where our physician builders are actively at this time looking at the tools that we have and what these new E&M documentation guidelines look like for complexity of medical decision making. And then it almost feels like trying to turn a gigantic container ship, because there's so much inertia at this point in what people have already created, the templates they've created, the tools they use, and it's both an opportunity, but it's also a challenge.
And I agree. And as we get more mobile, it's going to change too, right? Like our using mobile tools, which is the, someone commented on where the direction of medicine is. And I think it's going to be less desktop based, more mobile based. And so that's really going to add that other layer of complexity. Like, what will notes look like in the future? Like, how much do you actually have to document in a note? Like, I mean, just like maybe a paragraph of narrative might be enough. Who knows? And so keeping an eye on usability and what the future looks like. I don't know, Rod, Jeff, do you guys, as you're transitioning to mobile, are you having those conversations too?
We are, and we used our project as a little bit of a, call it burning platform, call it soapbox, whatever, to start changing that conversation about what goes into a note. We repeatedly show Chris Longhurst's data about the difference in note lengths between us and the rest of the world. And so that absolutely is going forward. Now, obviously, as one of the reasons that we went to Epic was interoperability. And hopefully as interoperability gets better, the reason that most people use for putting, there's really only two reasons people will use, maybe three, for putting everything in the note. One might be, well, I need to put it in there because I'm sending my note to somebody else. The other one is billing, which is hopefully going away. And then the third is some people still actually use the note as their data retrieval tool. But if we discount the data retrieval tool one, as interoperability gets better, as mobile gets better, hopefully people will have that data in the palm of their hands, so to speak. And so you don't have to have that argument for, I have to put in the entire echo report from last week because somebody might want to know what it is. You can just tell them to go look at the source of the data. So we're absolutely working on that.
Yeah, I think you can really separate the EHR into two pieces, and one of it is data presentation and the second one is data entry. And in terms of where I hope healthcare is going is what a number of different companies are working on right now, which is the AI and machine learning process that can actually listen in on the conversation between the physician and the patient, and then actually generate notes using that AI process. And I hope that becomes more mature. I've seen some demonstrations of that, but that, I think, from the documentation piece of it, or the data entry piece of it, which is such a burden on physicians. I hope we make some headway on that. Then as physician builders, if the AI process takes over, at least on that documentation piece, we may be spending more of our time really focusing on clinical decision support and data presentation to really have the information that people need at their fingertips and without having to go digging and searching through the chart. There's plenty of data on duplication of orders and just waste of healthcare resources by people ordering stuff that they didn't even know was in the system. And then also studies looking at mistakes that are made because people aren't able to find the information in the system.
And I think we found that with Epic going to storyboard recently, a new way of looking through the chart and looking through data. I don't know if your institutions have gotten to the point where you have storyboard on Epic, but that's just a new way to find information and jump to the chart. I've also actually started putting hyperlinks in our notes that allow us to jump to different regions of the chart. So I put some of the things that we need to remind physicians to do. We put hyperlinks in there, and we're actually hyperlinking out to our teams, our SharePoint team site, to give people some clinical data decision support. But you know, and then also like tools like Secure Chat within Epic have actually profoundly changed the way we interact as clinicians and nurses. And thank goodness, one of these days, my dream is to get rid of this thing. Right now I have them all routed to my phone, and then I have Secure Chat, but my dream is to get rid of this, so that they're all coming through the EHR and routed dynamically, and so that things actually end up in the place that they need to end up without having me to carry like 5,000 different devices.
Yeah, I don't know that there's a lot of other industries that still use pagers. Even those less than reputable industries who we used to say, it's only them and doctors that still use them, they've moved on. They moved on to smartphones. We have not yet.
It's okay. I have faith that you guys will get there. It's all right. Well, we appreciate again your all's time today. Thank you everybody who joined to the webinar and threw in some questions there. I'm going to hand it back over to Dwayne, who's our president, and he's going to talk through just kind of some of the events that we have coming up. I know we have another webinar tomorrow afternoon, so please join us then. Dwayne, go ahead.
Hey, thanks again, David, and to our panelists, thanks for that conversation. Hopefully we can continue to bring more conversations like this to this topic in the new year. I just wanted to let you know that tomorrow we have another healthcare IT policy conversation. This is with Tom Leary, who's from the National HIMSS organization. I think, as we all know, IT policy and what's coming from the government, how we pay for things, is a big part of what we can do. So looking forward to that tomorrow. And then Friday or Thursday, we're going to continue the conversation we started last week on the remote worker, kind of a pre-COVID, post-COVID. We have Ellen from Virginia Mason is going to have another presentation, and then we've brought back a lot of the panelists from last week are going to be on that one as well. So I hope you'll join us for those. If you miss any of the seminars, these are all going to be on the HIMSS Washington website coming up. So join us there. Thank you very much for all you do and for participating in these summits, being an attendee, wanting to learn, and we look forward to seeing you in the future.